Welcome to NCLEX RN Review, produced by Nursing Tutorial and Consulting Services. This session is on respiratory. I'm Judith Miller, and I'll be your guide as we talk about respiratory conditions. We want to start first by looking at some of the assessment tests. And the first one I want to look at is obtaining arterial blood samples. On the Essential Concepts tape, we talked about blood gases and interpreting blood gases, but we did not talk about obtaining the arterial samples. Since it is an arterial sample, we have to be particularly conscious about putting pressure over the puncture site until it stops bleeding. And this could be as much as 2 or 3 or 4 minutes. In addition to that, make sure that the sample is gently rotated because it's put in a heparinized tube. We want to keep it cool. So sometimes it's put on ice, but it's kept cool and transported immediately to the lab. We don't want metabolism to occur, because if that happens, then you don't get accurate oxygen levels. Other tests that we want to look at, we know they've asked questions about obtaining a sputum culture. They've asked about what time of day you should obtain it. The best time, if you can, is first thing in the morning, because there's usually the greatest concentration of organisms at that time. They've also asked about if you should rinse the mouth, and if so, with what. Rinsing with water helps to remove any debris or things that might be in the mouth. You should not use mouthwash, especially alcohol-based mouthwashes such as Listerine. You don't want to rinse a specimen for culture with alcohol. They might also ask you about a thoracentesis. Centesis means the removal of air or fluid from a body cavity, and in this case it's the thoracic cavity. Usually this is done at the bedside, and the nurse's task not only is to make sure there is a signed consent form, but to position the patient properly. So the patient is usually sitting upright on the side of the bed. And I like it when they can lean over onto an overbed table. That just helps make it a little bit sturdier and keep the patient safer if they should get a little dizzy during the procedure. A bronchoscopy. Oscopy is a look-see, so they take a scope and put it down the trachea and then down one or both of the main stem bronchi. The patient will be NPO before the procedure, and then since they use a lidocaine spray to deaden the gag reflex, they will be NPO after the procedure until the gag reflex returns, which could be anywhere from a few minutes to no more than a couple of hours, depending upon the product used. Most patients who have a bronchoscopy will also have conscious sedation, so you would want to monitor vital signs until they are stable following the conscious sedation. We also want to talk about the tuberculin skin test, variously called the Mantoux test or the PPD, Purified Protein Derivative Test. This test is given intradermally, so that means that you give almost flat, not more than a 10-degree angle into the forearm that raises a little wheal, W-H-E-A-L, or bleb. You want to circle where you planted that test. And 48 to 72 hours, we need to read it. You read it with your fingers, not your eyes. Induration is raised area. Redness doesn't count. Redness is just minor skin irritation. So raised area. 10 millimeters or more of raised area tells us that the patient has antibodies against tuberculosis. This is an antigen antibody test, and it tests for the presence of antibodies against tuberculosis. What that means to the person born and raised in America is that tuberculosis organism has entered their system and they have developed antibodies to fight it. It does not say who won the fight, tuberculosis or the patient's body. Now, much of the rest of the world, most of the rest of the world, immunizes against tuberculosis. We don't in America, but most of the rest of the world does, and patients will we'll get something called BCG vaccine. And the purpose of any vaccine is to stimulate the development of antibodies against the disease. Persons who have had BCG vaccine will have a positive skin test. And if they do, it may simply mean that their vaccine is working. However, when you have questions on NCLEX about tuberculin skin test, you should interpret this from the perspective of persons born and raised in the United States, because this is a test of nursing practice in the United States today. So when you are reading a question on the exam, you want to think in terms of someone who has never had BCG vaccine. Now I want us to think about a few procedures related to the respiratory system. And the first one that I'm going to look at relates to the chest bottles and chest drainage system. In order to think about chest drainage system, we need to think about why would a person need chest drainage. And one of the common reasons for needing chest drainage is pneumothorax. So if we take a look at our picture on pneumothorax, I want you to note first this side over here is a normal lung. It's properly inflated. This is a normal lung. Now over here, we have air entering into this pleural cavity, and the lung has collapsed. It looks like maybe they had an argument and there's a stab wound, and the lung has collapsed. Now let's review a little bit of physiology here. Normally, in this pleural cavity, outside the lung but inside the cavity, so right along in here, the pressure is less than atmospheric air. And that's what allows air to rush in and fill up the lung. It's a pressure gradient. It will go from high to low. Now on this side, with the stab wound, we have air in the pleural cavity. Now there's no pressure gradient because this is atmospheric air. It's the same pressure as atmospheric air, so there's no pressure gradient, and the lung will collapse. In order to let that lung reinflate, we have to figure out some way to get air out of the pleural cavity without letting any air back in. If you just stuck a tube in here, air could go both ways. So they figured out that if we stuck a tube in the cavity and put the other end of it under water, it's kind of like blowing air out of a straw. Bubbledy, bubbledy, bubble, but you could not breathe in through the straw. So this allows air to leave the pleural cavity without any air getting back in. We have water seal. And we need to look at those bubbles because they love to ask you bubble questions on NCLEX. Now the bubbles in water seal represent air leaving the pleural cavity. So those are air leaving the pleural cavity. It comes out and goes bubbledy, bubbledy, bubble. If there are no bubbles in water seal, it means one of two things. It means either the lung has reinflated and there is no air to come out, or there is an obstruction in the tubing. The patient is lying on the tubing, or maybe there's a clot in the tubing. So let me say that again. If there are no bubbles in water seal, it means either the lung has inflated or there is an obstruction in the tubing. Now you need to think about the time frame. If it's 2 hours after the tube was inserted, it's most likely obstruction of some type. If it's 2 or 3 days after, it's more likely to be that the lung has reinflated. Now, people get a little bit impatient and they're saying, can't we move this stuff out faster? And there's wall suction on the wall behind the patient. So they say, let's figure out a way to use this wall suction instead of being dependent on gravity drainage. So we can use wall suction. Now, when we take a look at this, we have to have a way to control that suction because wall suction is uncontrolled suction. And take it from me that the way to control suction here is the length or the depth of this glass rod, how much of this is below the water surface minus how much of this one. So it's actually how far this is below the water minus this. So in this case, this is 15 centimeters. This is 2 in the water seal. So that's 13 centimeters of water pressure. And this is pretty normal. It's usually about 12 to 20 centimeters of water pressure. And we need to look at the bubbles again. In the suction control, there are bubbles. And these bubbles come from air being pulled in here to equalize those pressures. So these bubbles come from air being pulled in. These are continuous bubbles because this is continuous suction. If there is no bubbling in the suction control bottle or chamber when we look at that system, no bubbling in suction control, the first thing you check is the suction turned on. If the suction is not on, there'll be no bubbles. Then if the suction is on and there's still no bubbles, we have to check for air leaks. So we would be looking to see, did somebody put a safety pin through this tubing? Has it come disconnected at some point? Is air entering the system some other way? Now let's recap that again. Suction control should have gentle, continuous bubbles. No bubbling in suction control. The first thing you check is the suction turned on. Second thing is for air leaks. In water seal, you should have gentle, but it's intermittent bubbles. If there's no bubbling in water seal, it's either re-expansion or obstruction. Now, when I repeat something so many times, there's all these bubbles, that means it's important. Sometimes they have bubble questions on NCLEX. All right, now this system works quite well. But some patients have something called the pneumothorax. They have blood in the pleural cavity. So if we take a look at this, what we see here is we've got bloody drainage coming out. Well, that's going to affect the suction because remember, it was the suction or the pressure was the difference between the depth of the rod in the suction control bottle minus the depth of the one in collection or water seal. So now we don't have any suction, so they said, okay, we can solve that problem. What we will do is add a third bottle. So now we have a collection bottle or chamber. Notice there's no opening to air here. So all that happens here is the fluid just drops. Then we have water seal that has intermittent bubbles. And then we have the suction control that has continuous bubbles. And remember, once again, if there's no bubbling in suction control, the first thing you check is the suction turned on. Second thing is for air leaks. If there's no bubbling in water seal, it means either re-expansion or obstruction. Now, this bottles, actual use of physical bottles is really quite old-fashioned. You'll see it used occasionally in some places, but most people are using a portable water seal drainage system. And that looks something like what you see on the screen now. This is really 3-bottle drainage. It's simply in a plastic case. So if you'll note, we have the collection chambers. We call them chambers now instead of bottles, but we've got collection chambers. The nice thing about this is they have numbers written on it. So you simply have to mark on here the date and time, and then at the end of your shift you can know the date and time, and you can know exactly how much was drained out during that time. We have the water seal chamber into which you will put 2 or 3 centimeters of water, and the suction control chamber into which you usually put 15 to 20 centimeters of water. The bubbles are just the same as we talked about. If there are no bubbles in suction control, It means the first thing you check is the suction turned on. And then if it is and there's still no bubbles, you check for air leaks. If there are no bubbles in water seal, it means either re-expansion or obstruction. Most of the time you're going to see this portable water seal drainage system, either Plurivac or Thoraclex, or several brand names for this product. Let's look at a question. The nurse enters the room of a client who has a portable chest drainage system in place. There is no bubbling in the suction control chamber. What should the nurse do initially? 1. Listen to breath sounds. 2. Notify the physician. 3. Check to be sure the suction is turned on. Or 4. Observe for obstruction of the tubing. Now this said there was no bubbling in the suction control chamber. So the first initial thing you do is number 3, check to be sure the suction is turned on. Another question for us. The nurse caring for a client who has portable water seal drainage in place notes there are no bubbles in the water seal chamber. What should the nurse do initially? 1. Turn off the suction. 2. Listen to breath sounds. 3. Check to see if the suction is turned on. Or 4. Observe the client for difficulty breathing. Now this says no bubbles in water seal. And remember that if there were no bubbles in water seal, it was either re-expansion or obstruction. And the one answer that tests about re-expansion is to listen to breath sounds. So you'll take out your stethoscope and auscultate. If you hear breath sounds in both lungs, in all sections, then the lung is probably re-expanded, and that's why there's no bubbles. If it has re-expanded, then the physician will probably order a chest x-ray to confirm that, and the chest tube will be removed. Now when the chest tube is removed, you want to have readily available for the physician an air-occlusive dressing. Now it's going to be called Vaseline gauze dressing, but on the exam they're going to call it a petroleum gauze dressing because they don't use trade names. So your air-occlusive or petroleum gauze dressing should be readily available. When the tube is to be removed, the physician usually asks the patient to either take in a big deep breath and hold it, or to hum, to go so that the patient will not breathe in when he yanks the tube out, because there would be a chance then that they could pull air back into the pleural cavity. So he yanks the tube out, puts the air-occlusive dressing on, it will very quickly seal itself off. Now I want to pose another question or two for you. You're working on a thoracic unit. You have a patient that has a portable water seal chest drainage system. And this patient is a little bit confused perhaps. But this patient has managed to pull the chest tube out from the chest wall. So now he's pulled the chest tube out and you've got this open hole here. What are you going to do? You need to cover that so that air isn't going to go back in and further collapse the lung. So this is when you need air-occlusive dressing. Or they might ask, what should you keep at the bedside of this patient? Air-occlusive dressing. All right, it's a busy day on your thoracic unit. You just dealt with this emergency, and across the hall is another patient, also with portable water seal chest drainage system. And somehow, I don't know how, he has smashed, broken the system so that this portable water seal chest drainage is all smashed and broken. The chest tube is still in the chest wall. In fact, it's dangling out of the chest wall now. But the system is broken. You cannot reconnect the system. It is broken. What are you going to do? Now, the best thing to do, the best first choice to do, would be to stick the end of that tube in a glass of water. and that will create water seal. If you happen to have sterile water, so much the better. If not, use the water glass, because what you're doing is recreating water seal and preventing further collapse of the lung. We no longer clamp those chest tubes, because that causes changes in the pressure in among the delicate pleural tissues in there. So it would be much better to stick the tube in a glass of water than it would be to clamp the tube. Many years ago, we used to do things like stripping or milking chest tubes. We don't do that anymore either, so that would not be an appropriate action for a patient with chest drainage. You do not empty the chest drainage system. Most of the time, you simply don't need to. It's got enough chambers in there, so you don't need to empty it. About the only time you'd have to change the system would be possibly in the emergency room or the operating room, but on a patient care unit, you would hardly ever need to do that. All right, let's move on and talk about some other things that we do for patients with respiratory issues. Chest PT, or chest physiotherapy. This is done usually for patients who have severe lung congestion. Postural drainage. We'll probably use the percussion and vibration first, and that's to loosen secretions, and then we will position the patient to promote drainage of secretions. Now, you might say, why are we talking about this? Because respiratory therapy takes care of this. Sometimes, much of the time, but this is one of those kinds of things that if respiratory therapy is not available, nurses need to be able to do chest PT. So the percussion and vibration the purpose of that is to loosen secretions, and then you position the patient to promote drainage. So if you wanted to drain the left lower lobe, you'd want to turn the patient on their right side with their head lower than their chest. And that would allow gravity to help them get out their secretions. Now, they sometimes have asked questions about when you would want to schedule chest PT. The best time to schedule it, if you can, is between meals and at bedtime. It's at bedtime so that we can kind of empty out their chest before they go to bed for the night. First thing in the morning is a good time as well. The worst time is right after a meal. If a patient has just eaten a big meal and you hit them on the back of the chest and turn them upside down, you might get back more than sputum. So we don't like to do it right after a meal. Another issue for us to look at is mechanical ventilation. We know there are a number of types of mechanical ventilation. We can have the air being administered as positive pressure cycled, meaning we're giving it at so much pressure. Sometimes it's volume cycled, and sometimes it's time cycled for so many seconds. I don't think that NCLEX is going to ask you which condition you would use which type of ventilator. I just don't think they'll ask that depth of a question. The question, in fact, that I am most aware of that they have asked about relating to mechanical ventilation has been the alarm goes off, what do you check first? The alarm goes off. You know most of the time it's a false alarm, but the first thing you check when the alarm goes off is the patient. You go in that room, is the patient breathing? If that patient is turning blue, you will beg the patient and get some help. Somebody else is going to check that ventilator and see what's going on with it. I mean, there could be moisture in the tubing. It could be something very simple. But the first thing you check is the patient. And that, I think, is probably the key element in terms of questions they might ask you about mechanical ventilation. Now, it does tell you on the slide that ADH can be increased during mechanical ventilation, ADH being antidiuretic hormone, and this could cause fluid retention. To my knowledge, they haven't asked that piece on the exam. It's true, but I don't know that they have asked that piece on the exam. Let's look at a question. The nurse is making a home visit to a client with severe COPD who has continuous oxygen. Which observation is of most concern to the nurse? 1. The home has an electric cook stove. 2. The client prefers cotton pajamas. 3. The home has wall-to-wall wool carpets. And 4. The home is heated with a fuel oil furnace. Now this is a tricky question, so let's take those answers one at a time. The home has an electric cook stove. This is not an issue. If it was a gas cook stove, we would be really concerned about gas and oxygen. We don't want an open flame with oxygen, but an electric cook stove is not a problem. Cotton pajamas are not a problem. They do not cause static electricity. However, synthetics could be. Synthetics, when you get static cling, what you really have is static electricity. And there's actually little sparks in there. So, cotton pajamas are good. Synthetic pajamas could be a problem. Wall-to-wall wool carpets, a common finding in America, but when you shuffle across wool carpets, you can create static electricity. You may have had the experience of walking across a carpet, particularly in the wintertime when the inside air is quite dry, and touching someone and having it be a shocking experience. You've got a little static electricity. This could create fire with open oxygen. So this is a serious problem. And in fact, this is the answer to the question, because you don't want that static electricity. Oxygen tanks have indeed blown up from static electricity created by walking across a floor with wool carpets on it. If the patient had this, you would want to suggest they put a cotton scatter rug or a cotton rug or a cotton sheet on where they're going to walk, because you want to reduce the static electricity. Now, I want us to think about option number 4 on that slide. Option number 4 says the home is heated with a fuel oil furnace. Now, with a fuel oil furnace, you do have an open flame. You do have a pilot light. The question is, how often do you have to go near that pilot light? And the answer is, not very often, maybe never. Most people will have somebody come and clean their furnace once a year, and it's automatic. There's nothing you have to do about it to light the furnace every time it needs to be lit. So, while 4 has a possible theoretical concern for us, this is something that the patient may never need to be exposed to. Well, answer number 3 is something they will be exposed to on a continuing hourly, daily basis. So answer number 3 is the answer to that question. I think that's a tricky question, actually. Now let's look at another one. The nurse is caring for a 4-year-old boy who is in a croup tent. Which toy is best to offer the child? A stuffed animal, a wooden toy, a mechanical toy, a toy car? Now this is again an oxygen safety question, because a croup tent is oxygen and also humidity. A stuffed animal, if you were to rub or pat a stuffed animal, you get static electricity, so that's not a good choice. A wooden toy, wood does not conduct electricity, so that's a good choice. Mechanical toy has moving parts which could create static electricity, and so does a toy car. So the correct answer is number 2, a wooden toy. Now, both of these questions talk about the concept of oxygen safety. A few moments ago, if I'd asked you about oxygen safety, you would have probably told me don't smoke. And you'd be right, but there's more to it than that. And I think the exam would be more apt to ask you a more subtle type of question. Now, if we think about some of the things that are important with oxygen therapy, certainly the safety issues we just talked about. Oxygen should be humidified. Any oxygen above 4 liters you're going to humidify. And sometimes there's nothing wrong with humidifying less than that, but it needs to be humidified above 4 liters. Most hospitals use 4 liters as a cutoff point because it's too expensive to humidify lower levels of oxygen. Now, I have been told by some people that there's been question about how far you insert the prongs with a nasal cannula. The answer is 1 centimeter. I think it's a silly question. Can you possibly insert the prongs too far? No, because there's a little crossbar on those prongs and you cannot insert them too far. But you should insert them about 1 centimeter. Let's look at another question. During suctioning of the client's tracheostomy tube, the catheter appears to attach to the tracheal wall and creates a pulling sensation. What is the best action for the nurse to take? 1. Release the suction by opening the vent. 2. Continue suctioning to remove the obstruction. 3. Increase the pressure. Or 4. Suction deeper. So just imagine yourself now suctioning that patient and it sort of sticks to the tracheal wall. The answer is number 1. Release the suction by opening the vent. Take your thumb off the hole. Now, why couldn't they say take your thumb off the hole? Well, they don't write questions like that. But you release the suction by opening the vent. That stops the suction. And that's the appropriate answer. Now, what would you do if you're suctioning a patient, doing tracheal suctioning on a patient, and they start to cough up big secretions? Would you continue suctioning or remove the catheter and let them cough it up? Remove the catheter and let them cough it up because their cough is actually more powerful than your suction. A couple other thoughts about suction. What would you do before suctioning? Oxygenate. What do you do after suctioning? Oxygenate. And how long do you suction at any one time? No more than 10 to 15 seconds. So 10 to 15 seconds is plenty of time to suction at any one time. And don't forget the hyperoxygenation before and after.